Hi there, my name is Carly Andrews. My title is Senior Project Coordinator for the North Dakota Brain Injury Network. You are viewing behavioral consequences of brain injury. These are our staff on the North Dakota Brain Injury Network. Rebecca Quinn is our director, and she lives in Grand Forks. We all live in North Dakota. Nicole Livdahl, or Nikki as we call her, she is our resource facilitator and she lives in Towner. And I am Carly and I live in Grand Forks. But don't let where we live influence your decision to reach out at all, because we do serve the whole state. So our referral form is available on the top right-hand corner of our website, which is www.ndbin.org. So check that out for more information as well. But here we go. This is, so hopefully you viewed intro to brain injury, cognitive consequences, and now we're on to behavioral consequences of brain injury. So one thing that Rebecca said one of my first days of work, and I love it, is brain injury is an explanation, not an excuse. So we are not excusing any kind of behavior here. We are explaining it, okay? So there are emotional and behavioral changes after a brain injury, and it's very chicken and egg. We don't always know the why. So it can be from the injury itself, depending on what region of the brain was damaged by the injury. It can be from the coping problems with the dealing with the injury. So brain injury is unique from other disability areas in that there's a distinct typically before and after. So that survivor typically knew themselves as someone. Now they had this brain injury and now they're a little bit different. So that can be really hard to cope with. And then pre-existing stuff. So again, they were a person before their injury. They are a person now, and they will have a lot of those same personality traits that will come with them, right? They don't just go away after a brain injury. So whether they were positive or negative personality traits, they could still be with that person. So again, this is kind of just another way of talking about factors that influence behavior. So the injury, the type of injury, the severity, the site of the injury, the individual, what were they like before the injury? What are they like now? You know, what deficits do they have? And then the environment, you know, where do they live now? Are things different? Is their environment different? Do they need grab bars everywhere? Are they in different classes than what they used to be? You know, I have one student that was never in special education prior to his injury and now is, and that's hard for him to, you know, go down to the special ed room. There's a stigma attached to that. So he really gives his special ed teacher a hard time, but he still needs her services. So that's a whole nother thing. But yeah, so things can really influence behavior, right? The injury, the individual, and the environment. So oftentimes after brain injury, we see what we call the cognitive behavioral spiral. And this starts out, this is kind of a visual of this. So it starts out with the cognitive deficit. So from the video before that I showed, or from the last video about cognition, you have those deficits, those like moving through fog and that delayed processing. And that makes us anxious and frustrated. And then that distracts us because our attention after brain injury is impacted, as you learned in your cognitive deficits slides. So that distracts me. And then I become less able to focus and concentrate, which causes me more anxiety. So then I just freak out. I, you know, throw my chair, I say F off or whatever it is that I do. I will say, depending on the kiddo, and a lot of the ones that I personally work with, the parents see the emotional outburst. The school doesn't always see it. So a lot of these kiddos do a really good job of keeping it together and saving face throughout the day and smiling and nodding and everything's fine. And then they get home and it's like meltdown, you know. So yeah, so you might get calls from parents like, oh, you know, had a terrible day. And you're like, what? They were fine. I didn't see anything. Brain injuries survivors are very good at that, saving face. So when any time there is behavior though, there are three main messages behind behavior. So there's typically either an unmet need. So this could be emotions. They could need a hug. This could be physical pain. They could need some Tylenol or some quiet room or a warm washcloth. This could be a lack of resources. This could be an expression expression of mood. They could be mad, they could be frustrated, they could be sad, they could be confused, they could be lonely. Now they don't have all the same friends they had before. And then it could be a response to stimulation. They could be bored, not have enough stimulation, or they could be overstimulated and have way too much. So typically there is some type of message that behavior is trying to send us. And so we need to put on our thinking caps and think about, what could this behavior be? And one acronym that I always routed back to especially when I was teaching, and now with what I do, is HALT. So when a student was in crisis, I would always think, are they hungry? Did they eat this morning? Check their book. I'd say the paras, check their binder. Did they eat this morning? Because I had communication binders. I taught students with intellectual disabilities, but I always asked parents and staff members if they lived in like a group home to fill out, so we would know, like, did they eat? Because if not, maybe they need a morning snack before lunch. A is agitated, which can be angry, and just bothered. Agitated looks different from someone with a brain injury. It's very exasperated. And we'll talk about that in a little while. L, are they lonely? Again, do they need a hug? Do they need a friend? Do they need a talk or a walk with someone? And then finally, T for tired, because as you learned in, I believe it was the introductory video, it talked about fatigue. Fatigue can be very overwhelming after a brain injury. And so oftentimes they might just need like a reset, a recharge, time to lie down in a quiet space. You are not reinforcing negative behavior by providing any of these things. These things are basic needs that people need in order to function. So don't worry about, well, they can't act like that and then get a snack, That's not what we're trying to do here. We're trying to be positive and proactive about this approach. So behavior. A lot of times there is some type of function to behavior, and that's what special education teachers are trained in, is FBAs, or functional behavior analysis. So we look at behavior and we try to figure out the cause. What's the function? Why are we acting like this? So let's look at this example here. An adult male yells and makes threats every time a non-preferred or unfamiliar staff member offers him his meds. His preferred staff member then arrives to help him calm down and to take his meds. What's the function? What do you guys think? He wants to escape, right? He doesn't want to be around those non-preferred people. He wants access to the people he knows or prefers, and he wants to escape from demands. So it could be both. Yes, we do need to learn how to work with everyone. So I wouldn't let him have that preferred staff member until he's appropriately asking for it, would be the way I would handle this one. And we still do need to take our meds, right? So we can't escape from all of those demands, and maybe just really explaining the importance of medication and what the medication is doing to help this individual and all of that. So we need to assess the behavior. And that can be as simple as ABC. So ABC is a good way of looking at behavior, especially when it comes to brain injury. So the A is the antecedent. What happened right before the behavior? What were you doing? What activity? So like in that last example, medication time, right? What happened? Let's look back. I can't remember exactly how they said it, but I believe they said, he yells and makes threats. Okay, so that's the behavior, yelling and making threats. So things like getting angry aren't behavior. I can't see that. It needs to be something that I can see. And then the consequence is what happened after. So he got what he wanted, right? He got that preferred staff member. And so that was his consequence. So in that instance, you are reinforcing that negative behavior by allowing him to have that preferred staff member. So anytime you see behavior, if you can document those ABCs, that can really help me help you come up with a better intervention. Okay, so I need to see the before, the actual behavior, something that I can see or observe, and then the consequence, what happened after. And it doesn't necessarily, like I said, consequences can be positive or negative. So we really want to, I can't say this so much, is to look at that antecedent and at that consequence, because then we can really look at that target behavior and really try to hone in on what's going on there. And we have found that brain injuries, respond best to positive reinforcement. So we'll kind of keep talking about that as we go. But if we can provide positive reinforcement or antecedent-based interventions as well as what brain injuries respond best to as well, positive and antecedent-based. So we can change the before the behavior, so we don't even get to the behavior. We're taking kind of a proactive approach, if you will. So some strategies that we can do, prompts and cues, is when we can prompt an individual to stay a correct response. So we can provide visuals, we can provide auditory, we can provide tactile, and we can provide environmental prompts. Okay, so a lot of these can really help going a long way with behavior if we provide all of these things that we're expecting. As far as giving feedback, we don't want to ignore behavior. We need to be as immediate as possible, and we need to be specific about why the change is needed. We need to be clear about how that impacts how their behavior impacts others, and provide a positive role model. We cannot assume that people know the right way. We need to explicitly teach a lot of things to brain injury survivors. So, and then we need to watch for those things that are reinforcing those challenging behaviors. Like, again, that example given, we let that guy have that preferred staff member, that behavior is just going to keep on happening. Okay, so we need to be clear, simple, and direct. So we can say things like, I don't like it when you talk about what, how large that woman is, or you are staring at that woman, she might feel uncomfortable. So we get a lot of survivors that, it's almost kind of reminds me a little bit of when my grandma had Alzheimer's, and she would kind of the early stages, and she would say a lot of things that were very inappropriate out in public, like, oh, look at that big fat lady, and that's kind of similar to what you might see from someone with brain injury. So we just need to say, nope, I don't like what you're talking about. You're staring at her, you're making her uncomfortable, and that's not nice, or whatever it is that you want to use, words you want to use. But we need to just be really brief and concrete and concise, because smoozing with a client with brain injury is a recipe for disaster. So we don't want to be a jellyfish. We need to be very firm and follow through with the consequences that we set up. So that's another thing when we write these plans together, and I can help you write those, these behavior intervention plans, that consequence is very concrete and consistent. We want to focus on the positive. We want to respond best to positive reinforcement. As I said, negative reinforcement and punishment are the least effective. So for those of you that watched Introduction, I talked about how 87% of individuals incarcerated have a history of a brain injury. Well, this is a perfect example of why. The ultimate form of negative reinforcement would be jail, right? And these individuals often don't learn from that time in prison, and they often end up reincarcerated. So we want to notice and encourage the appropriate behavior frequently. And I apologize for that picture being off. But yeah, high fives, whatever it is that individual needs for that positive reinforcement. We want to notice it, and thanks for coming. You're on time today. Look at you. Or look at, this is 2 appointments in a row that you've showed up. Just really, really honing in on that positive stuff. Our communication consideration. Look at her hands on her hips, right? She looks like she's got something, a bone to pick with you, right? We want to be aware of that. Where are our arms? Where are our hands? How does our face look? What's our tone, our volume, our cadence of speech? Are we yelling at someone? Are we getting loud? Or are we calm? And are we, keeping our voice at a natural tone? Okay, so brain injury survivors might not always remember you, but they're going to remember how you make them feel. So some interventions as far as crisis. We need to remain objective and neutral in the face of problem behaviors. We don't want to label individuals and their behaviors. Remember that behaviors are often related to the brain injury factors. They're often related to communication, a lack of awareness, to pain, but these things aren't personal. So I talked earlier about a young man, that before and after, he had never gone to special education before. Now he has to, and it sucks, right, for him. And so he's very hard on his special education teacher. And one thing, when she goes and gets him to, do some pull-out services, he will shout down the hallway like, she molests me and she touches me and things like that. And that's very hard for her. And she called me in tears a lot. And I just, it's not personal. He's taking out his circumstances on you. And then a huge thing is to document. I used to have a supervisor that would say, if it's not written down, it didn't happen. And I think that is a good rule of thumb to live by, as far as the classroom is concerned. And as far as, working with brain injury survivors, we need to document it. So we need to write things out like those ABCs so we can really, really see if we can find any patterns too. Some de-escalation techniques that we would recommend. So active listening, like, I understand you're frustrated. Like, I hear you. I know I can't help you do much about it right now, but I hear you. Just letting them know that they're not alone. Orientation. Let's go for a walk. Let's leave this environment. Let's, go do something else. Redirection. We want to distract to a more appropriate behavior. Setting limits, one of my favorites for that is an if then. So if you do this, then you get that, right? If we go to work, we get a paycheck, right? What's their paycheck? Think of that. Would you show up every day for work if you didn't get your paycheck? Probably not. And so we need to find that carrot, that paycheck for them. What are they getting out of this? Withdrawing attention is ignoring, right? So you can do that to a certain degree, depending on the behavior. Kind of pick your battles, if you will. And then contracting, we can, this is better for our higher functioning individuals, but outline of consequences for problem behavior. Okay, so if you do this, this is going to happen. This will be your consequence. That can be really helpful in swaying people to not make bad choices. Individuals with brain injury, it can be hard to tell, are they a won't or a can't? So we really want to make sure we tease that out before we get too far in the accusations of, this person is so lazy or they're just unmotivated. And so a can't is someone that literally has the inability or incapacity to do something. So is what we're doing, what we're asking them to do, too difficult for them? If you're struggling with that, we can try to help you determine that. And then, or is it a won't? Are they deliberately choosing not to act? So there's a huge difference between people that can't and people that won't. And we need to kind of determine that as far as our behavior plan of how we're going to address it. The 3 I's is something we refer to a lot: impulsivity, irritability, and impatience. So these are all classic hallmarks of someone with a brain injury. And these are all classic hallmarks of a lot of us, right? A lot of us, we get hangry. Hangry means we're so hungry that we get a little bit angry or crabby, right? We all do this to some level socially, but someone with a brain injury, it's much more exasperated. It just looks a lot different than it does for someone without a brain injury. And oftentimes they will exhibit, poor social skills. So they'll have inappropriate behaviors, they'll inability to inhibit remarks. Like I said, look at that lady, she's so fat, from the few slides ago, that would be one example of that. And then there's oftentimes an inability to recognize those social cues. One example I like to give is one of my first days on the job. We had an event and this woman was chatting with us after the event, and we were packing up all of our stuff and getting ready to go, and she still kept talking. She was not picking up on that the event was done and it was time to go. We needed to explicitly say that to her, and it feels like you're being kind of rude, but I don't think it's taken that way by them at all. I think they need that. They want you to tell them what's expected of them. Oftentimes we see either a reduced self-esteem or an overinflated sense of self. It's kind of one or the other. Rarely do we see that in between. And then, stress, anxiety, frustration, and reduced frustration and tolerance. Again, they have just a lower tolerance for all of these things, and things that, might seem very minor to you might be a huge deal to this person. I really like this infographic because, again, it shows the dimensions of irritability. It's not like, oh, you're just being moody. right? So there's moods and feelings to think about. There's self-control and time management. There's negative self-thoughts, that interpersonal communication, and that environmental. There's all that stuff that compacts together to kind of make a person irritable. Okay. And then here is what I really like, the what it looks like, if you want to pay attention to those and the triggers. But again, that affective, that looks like moodiness or snapping or anger or agitation. Some triggers, they might feel overwhelmed, they might feel pressure, they might feel out of control. Again, offering those control things. You want to write with blue or red. Time management, self-control type things can look like a loss of control. That can be throwing things, slamming doors. Some triggers, they might have procrastinated or trying to do too many things at once. That overwhelm, right? Negative self-talks, they could be brooding about past events or abilities. A lot of my survivors hang on to this, but months ago I could do this. I used to be able to read just fine and now I can't. Or I had all these friends and now I look different and I act different. Nobody wants to talk to me anymore. So there's kind of that negative social comparison, dissatisfaction with themselves. Interpersonal communication, difficulty with small talk and nonverbal communication. So the family members oftentimes see this a lot. The roles might have reversed. There might be, implications from this injury that changed this person. And so there just might be struggles with that communication piece. And then finally is that environmental, that sensory overload, changes in routine, that there can be some agitation, anger, snapping type things, diminished daylight. So think about like winter time. I think a lot of my clients carry like a SAD, like a seasonal affect disorder diagnosis as well. So they'll use the lights and things like that in their homes. Crowds, unexpected changes to a routine or a schedule. That's why we want to have those cues and warn about, in 5 minutes, we're going to gym class or whatever it might be, or, we're going to be going to the pep rally today and there's going to be a lot of people there. There's going to be a lot of noises. And so that's why I do like the use of social stories as well to kind of combat some of this. So again, it's different for those with a brain injury than it is for your everyday person. So it's much more extreme. It's a lot of times disproportionate to the circumstance. They might get a paper cut and be sobbing about it. Most of us can take a breath and move on. Sometimes it might not look like there's a trigger, but a lot of it might be more that internal, like that negative self-talk piece or that kind of internal frustration. It might be more frequent than your typical person. There may be other factors, cognition, pain, fatigue. Again, we want to think back to HALT, right? They need a snack. They just need a break. So brain injury population can be tricky as far as behavior. They don't respond well to regular behavior modification. Like I said, negative reinforcement like timeout, jail, tickets, fines. Person with brain injury is not going to learn from that. We need to find that antecedent, find out what's going on right before the behavior. Why are you acting that way? And let's make it better. Let's be proactive about it and not even get to the point of having behavior. They might have a lack of awareness of their own behavior. They might not, be aware of what's going on. They might have a lack of impulse control. One of the classes I teach, we work a lot on stop, think, plan, then do. And one of my co-teachers, he talks a lot about how that's the Roomba model, right? So the Roomba, like the vacuum cleaner that we use at home, it'll kind of, if it runs into an object that it can't clean up, it will stop, it will turn around, and it will kind of recalibrate. So that's kind of his example of talking about that. And then, those behaviors can really impact friendships. They can impact school life. I do have one survivor that acts much differently than she did when she was younger because she has a tumor now, and I think that's really scary for her classmates. So even having we can come in as Brain Injury Network and do brain injury day and teach about brain injury and try to destigmatize. That's totally a personal choice if that's something you want to do, but that is something we have done before and it was pretty successful. Brain injury is a chronic condition, so there's no cure. There are many treatments available, options available out there, and that's our job, is to help you navigate that process. So please let us know if we can help at all. And again, no cost for our services or any of that. So give us a buzz and see if we can try to help you navigate this brain injury world. So thanks for listening. Talk soon.